Hello everybody, welcome to today's podcast. My name is Dr Margaret Mascarenhas and I am a GP Training Programme Director in Wolverhampton. Today I am delighted to be joined by a very special guest, Professor Michael Harris. Professor Harris, thank you very much for joining us today. How are you?
I'm fine, thanks, Margaret, and thanks for inviting me to your podcast.
It's a pleasure. Professor Harris, can you tell us a little bit about yourself?
I've worked as a GP for 30 years in the West Country of England, near Bath, and I was an examiner for quite a few years. And I ran the Bath Release course. I was a training programme director in Bath and Swindon for many years. And in the last few years, I've concentrated my academic work on research, early diagnosis of cancer in primary care, in a European context, and teaching, particularly teaching about research and research methods.
Can you tell us how you came to write the wonderful book with your co-author, Medical Statistics Made Easy?
A few years ago, I was teaching on the release course, and the GP registrars asked me to run a session on medical statistics for them. And I didn't know anything about it, so I had to learn enough to be able to teach them about it for an hour. And then, to my surprise, a few days later, I had an email from a medical publisher asking if I would write a book on medical statistics. And I couldn't do that by myself, but I teamed up with a professional medical statistician, who's Professor Gordon Taylor from the University of Exeter, and we co-wrote a book called Medical Statistics Made Easy.
I have thoroughly enjoyed reading your book. It is a really wonderful book that explains all the concepts so well. A big thank you for providing this amazing resource.
It's my pleasure. I'm glad it's being helpful.
Today, we're going to discuss why it is important for GPs and GP registrars to understand how to interpret data. We are going to provide a transcript for this audio, and we would encourage you to perhaps listen to the podcast in its entirety. And then you're welcome to revisit the statistical terms and perhaps use that as an opportunity to look them up.
Thanks, Margaret. Being able to interpret data is really important to us as GPs, and I'll tell you why. To give good care to patients, we need to seek out the relevant clinical evidence and then evaluate it. But to be able to evaluate a piece of evidence, which may be a research paper or an article, we need to be able to find out which research method has been used and why. We have to know the basics of how that research method works. For quantitative research, that's research with numbers, we need to be able to interpret the results, which means knowing how to understand the statistics that describe those results. We don't need to know how to do the statistics, but we need to know how to understand what they mean. Then we need to decide whether or not to change our clinical practice in view of that clinical evidence. There's a huge range of different research methods and statistical techniques, and in this podcast I'll go through the important ones and explain when they're used, but there isn't nearly enough time to explain all of them in detail. So this podcast in effect gives you a signpost to the relevant terms. Medical research is about answering a research question. When we see a patient, we may ask ourselves, what's the best way to look after this patient? Is treatment A better or worse than treatment B? What do patients with this condition worry about? How can we best help them? Medical researchers translate our clinical question into a research question, and that's what research papers try to answer. They pose a research question and they explain how they're answering it, and they tell us what the answer is. So if we're looking at a research paper, the first thing to do is find the research question. Is it relevant to our clinical practice? If it is it a question about how or what people think, or is it about numbers? If it's about what people think, it's called qualitative research. If it involves numbers, it's quantitative research. So let's discuss that first. Quantitative research answers research questions by collecting numbers, known as numerical data, and then analyzes those numbers with statistics. And there are different types of quantitative research. So let's go through which ones are used and when. Let's say we're interested in whether marathon runners eat apples and the effect that it has on their marathon performance. Many thanks to Professor Gordon Taylor, statistician from Exeter University, for these completely fictitious examples. We could start with a descriptive study. We could survey a sample of marathon runners and ask them how many apples they ate in the last month, and we would use descriptive statistics to describe the results. What percentage ate any apples? What was the average number that they ate? This could be given as a mean for evenly distributed data or a median for skewed data, with an indication of the spread of those answers using standard deviation, or SD for short, for means, or interquartile range for medians. We could find out about the incidence of eating apples, how many started eating them in the last year, and the prevalence, how many are eating them today.
So the terms that we've covered so far are descriptive studies, percentage, mean for evenly distributed data, median for skewed data, standard deviation, interquartile range, incidence, and prevalence.
If we found out that in a sample of 100 marathon runners, 30% of them eat apples, how near might that be to the percentage of all marathon runners across the country who eat apples? A statistician would calculate something called a confidence interval to tell us that. So we need to be able to interpret that. Then we may want to know whether there is a significant difference between the number of men and women who are eating apples, and we could use a chi-square test for this. The p-value is the end result of this and a lot of other statistical calculations, so we need to be able to interpret it.
So the terms we've covered so far are confidence interval, chi-square test, and the p-value.
In this case, the p-value from the chi-square test would tell us if there really no difference between the groups, how likely is it that we'd have got the difference we found in this group? If the result was unlikely to happen by chance, with a p-value of less than 0.05, we say this is statistically significant. It's a really important concept. If we see that a p-value is less than 0.05, it means there probably really is a difference between the two groups. We can look for an association, known as a correlation, between the number of apples that runners eat and their marathon times. Do marathon runners who eat apples tend to have faster marathon times, slower times, or is there no pattern? Researchers use an R value, spelled with a little r, as a measure of that, so we need to know how to interpret an R value. But all this means is that there's an association. It doesn't give evidence of causality. It's not evidence that one causes the other. It may be that there's a confounding factor, that there's another underlying cause for this association. For example, marathon runners who eat apples may be more or less likely to drink more coffee, and that's the real reason for the link with their marathon times.
So the terms we've used so far include association, correlation, R value, causality, and confounding factors.
What if we're interested in a rare outcome? For example, what's the association between regularly eating apples and actually winning marathons? Then we would need to do a case control study. Cases are the runners who have won a marathon, and controls, runners who have not won a marathon. And the predictor we're interested in is self-reported regular consumption of apples. And we would use an odds ratio to compare the two groups.
So we've looked at case control studies, predictors, and odds ratio.
Let's say that the preliminary results from our cross-sectional and case control studies suggest there is a link between eating apples and improved marathon times. But that's an association. It hasn't shown a causal link. So the next step is to do a prospective cohort study. This is a comparative observational study in which the marathon runners are grouped by their exposure status, whether or not they eat apples, and then follow them up over time to see what their marathon times are. So a cohort study starts with the exposure, not the outcome. And we use a risk ratio to compare the results for the two groups. It gives some evidence as to causality, that it's the exposure, which is eating apples in this case, that has caused the difference in marathon times. But as with correlation, there may be confounding factors that explain the findings. This is an example of what is known as bias, which is a systematic error in the study that affects the results. I've already mentioned coffee intake as a possible confounding factor, and another possibility is that people who eat apples may be more or less likely to do pre-race stretching exercises, and it's that difference in whether or not they stretch before a race that causes the difference in their marathon times.
Thank you. So we've looked at cohort studies, risk ratio, causality, and bias.
So now we need to consider doing a randomized controlled trial, RCT for short. If we randomize marathon runners to either eating apples daily or, let's say, eating oranges as a control, we can compare their marathon times. The randomization to either eating apples or eating oranges reduces the risk of bias. And if we're evaluating RCTs, we need to know about concepts such as blinding, cluster randomized controlled trials, and parallel group randomized controlled trials. Again, the likelihood of real differences between the two groups is measured with a p-value.
Thank you. So we've looked at randomized controlled trials, randomization, blinding, cluster randomized controlled trials, and parallel group randomized controlled trials. Finally, we have to look at the p-value once again.
When we're looking at p-values in randomized controlled trials and other quantitative studies, we need to be aware of two possible types of error. One is called a type 1 error. Think of it as a false positive. Apples don't really have any effects, but the study erroneously suggests that it did. And if p is 0.05, that means there's a 1 in 20 chance this was a false positive, or type 1 error. The other is called a type 2 error, which is a false negative. Think of it as a detection failure. That's if apples really do have an effect, but our study didn't find it, possibly because the sample size was too small.
Thank you. So looking at the p-value, we could have a type 1 error or false positive, and we could also have a type 2 error or false negative.
Perhaps we want to compare how many months or years it takes new runners in each group to start winning marathons, and the authors may use a survival analysis technique. A common method for survival analysis is the Kaplan-Meier method to measure any differences over time between the two groups.
So that's survival analysis technique and the Kaplan-Meier method.
Perhaps a few other researchers have already published papers on this. A systematic review identifies the evidence by summarizing the healthcare literature through a full literature search and critical appraisal of individual studies. Then, have several studies all examined the same numerical research question? If so, we may find a meta-analysis, a statistical synthesis of the numerical results to get an overall view of what the research shows. If we're looking at a meta-analysis paper, we need to be able to interpret a forest plot and a funnel plot.
Thank you. So we've talked about a systematic review, a meta-analysis, a forest plot, and a funnel plot.
Running a marathon is really tough and not everyone can complete them. Let's say researchers have found that eating apples reduces your risk of failing to finish a marathon race. How can we describe that change in risk? There's a variety of ways in which we can describe a change in risk of something happening, and they're commonly used, so we need to be aware of these. Absolute risk reduction, relative risk reduction, number needed to treat or number needed to harm, and Kate's plots are the most important ways to describe that change in risk. So as GPs, we need to know what they mean when we see them.
Thank you. So we've talked about absolute risk reduction, relative risk reduction, number needed to treat, number needed to harm, and the CATES plot, which is spelled CATES.
Another topic that we need to know about to be able to interpret evidence is diagnostic testing. How good, for example, is a new diagnostic test for finding or excluding an illness? And for that, we need to be able to understand and calculate sensitivity, specificity, predictive values, and likelihood ratios. These are relatively simple calculations that you can do yourself.
Thank you. So we've talked about sensitivity, specificity, predictive values, and likelihood ratios.
We've been talking about the concepts that you need to understand for quantitative research. Equally important for GPs is being able to understand and evaluate qualitative research, research about what people think. Let's say that we want to find out what marathon runners think about using apples to help them with their preparation for marathons, or why they use them. That needs a qualitative approach. We can get data on this through interviews, focus groups, or surveys. Researchers can use more than one of these methods, for example, using open-ended questions in a survey as well as interviews, and see how the results from these methods compare. That's called triangulation.
So for qualitative research, we're looking at interviews, focus groups, surveys, open-ended questions, and triangulation.
For qualitative studies, we need to have an idea about different possible methods of sampling from all the marathon runners out there. Be aware of qualitative sampling methods called stratified, convenience, maximum variation, and snowball sampling.
Thank you. So we've talked about sampling methods, stratified sampling methods, convenience sampling methods, maximum variation sampling methods, and snowball sampling.
Another bit of qualitative research jargon that you need to be aware of is data saturation, where we keep collecting data until we're not getting any new information. And this means that there's no minimum or maximum number of interviews or participants. We also need to know about a common qualitative analysis method called thematic analysis. In primary care, we often see what's called mixed method studies. This is where researchers combine qualitative and quantitative approaches in a single study.
We've discussed data saturation, thematic analysis, and mixed methods, combining qualitative and quantitative approaches.
And finally, when we've read and understood the results of any study, we need to decide whether they are likely to be valid. That means, how well do the results from the study participants represent true findings among similar individuals outside the study? Do the results represent the truth in the population we're studying, so are not due to methodological errors? This is called internal validity. Then we need to decide whether they're applicable to other groups of patients, not just the ones that the researchers have selected. That's called external validity or generalizability. For example, a study on marathon runners in a very hot country may not be generalizable to runners in the UK.
Thank you. So we've talked about validity, internal validity, external validity, and generalizability. Thank you so much, Professor Harris. I hope our listeners have found it really helpful to use this research question as a storyboard, meeting all of the statistical concepts that you are likely to come across in primary care.
Well, in this podcast, we've covered around 70 different statistical and research concepts. I suggest that our listeners use this podcast to give them some signposts to what they need to know in relation to medical statistics and basic research design. So I think use this as an introduction and giving you some pointers rather than giving you complete expertise in the subject. Please use this podcast and the transcript as a start point for your studying.
Thank you so much, Professor, for all of your time today. We are really grateful for this wonderful podcast. Thank you.
Thank you for letting me join you.